Good morning and welcome from all around the world to Structural Heart Life Cases, broadcasting directly from the Cardiac Catheterization Laboratory of the Mount Sinai Hospital in New York City. My name is Pedro Moreno, and I will be your moderator today. Remember, we'd love to hear from you. So send us your questions directly on the website or on YouTube. And you can review all our previous Structural Heart Life cases at ccclivecases.org. And now let me transfer you to the cardiac cat for a very interesting case.
Okay, good morning to our viewers of Structural Live Cases, and this is, we call it academic year. So we have three fellows, and besides myself, Dr. Keeney, Dr. Tang, and Kira, and we have on the echo, Dr. Lirakis. I know announcement was for Dr. Safi, but we changed it to because she is busy with kind of jury duty nowadays. In the past, with a little letter, you used to come out, but now you cannot come out with that. So therefore, but we are still the beat goes on. If we can do this, welcome everyone for this very interesting case of the valve in valve tower, and if we can show the slide, which is our supporter, and where is this? I don't know where things are. Okay, so these are, all of here, and of course, cardiac anesthesiologist is Casey Drubin, and Pedro with the moderator. Now, this is very good. It's a valve-in-valve SAPIEN-3 Ultra Resilia valve tower in the failed Edwards Inspiris surgical aortic valve. Nowadays, everybody talks about Chat GPT. So we put this one, told Chat GPT, what does it mean? What is the title? Guess what title they gave? Gilbert, you want to listen to this? Here. Title they gave it, A Second Chance for a Surgical Valve. I thought it was very funny.
That's pretty good.
But that's exactly came out from there. Okay, besides that, it's episode number 83, 69-year-old patient who already have multiple valve replacements, a few years ago, 2022, and having symptoms for last 6 months. Patient has a aortic valve replacement, mitral, and the tricuspid repair, and also have some vascular injuries, had a Covera stent, but more importantly, he had a valve called Edwards Mitris valve, which is supposed to be Resilia on the Edward, and I'll show you the data of the surgical valve, how good they have been. And this patient although had only in 2022, and we'll ask our surgical expert Gilbert maybe to comment on it. A patient with bioprosthetic AV degeneration, mitral was fine, and with the high gradients here, some regurgitation, but more stenosis, and good medical therapy as shown here, and has a non-obstructive CAD. So coming back to the point, this is the transthoracic echocardiogram, and this is, we should be playing these images, but anyway, we'll get the live image. So before we go on to, Gilbert, you want to comment on that? The valve, surgical valve lasted just under 4 years.
Yeah, it's a little unusual for that to happen because, this is the actual Resilia tissue within Inspiris valve. The Inspiris valve we'll show a little later. It's not a fracturable valve, but it can actually stretch. So the smaller annulus, basically, there's a hinge that you can actually stretch to accommodate the specific design for future TAV itself. But a little bit unusual that there was nothing on the CT scan or echo that, I don't know, maybe Stem can comment why it may have failed early, but, we are now dealing with the situation.
Okay. All right. So let's go to Stem. Show us the live, your echo feed.
Yes. Yeah, thank you, Dr.
Go to
Sharma.
the live echo, please. Yeah.
Thank you, Dr. Sharma. Good morning from New York. I have here our structural imaging fellow, Dr. Kassem, and our best structural sonographer, Hafiz. As you can see here, we start from the left lateral appendage, which appears clean, normal LV function, and RV is mildly dilated with mild decreased function. This is the prosthetic mitral valve. As you can see, the leaflets are thickened, and two of them are not moving well. No valvular or paravalvular mitral regurgitation. Peak gradient is about 10 in different measurements, so this valve has to be tackled at a later point as the discussion will follow. Minimal pulmonary regurgitation. As we say, status post tricuspid valve repair, as you can see here, with minimal tricuspid regurgitation. We come into the aortic valve, to the bioprosthetic aortic valve. As you can see, the leaflets are thickened,
So
calcified with decreased motion. As you can see, the turbulent flow through the aortic valve, short axis and the long axis. As you can see, the leaflets open, they're thickened, but don't open it very well. And again, the turbulent flow. And this deep gastric image, you can see, appreciate very well the turbulent flow through the aortic valve, through the degeneration. And here are some gradients. We got a peak velocity of 3.5 in the pre-TE that we did a few weeks ago was about velocity of 4. The aortic valve area here is 0.8. The deceleration time is 87 milliseconds. So I think it's a combination of degeneration with some ppm. And this is a deep gastric image of the LV function, normal LV function, and as you can see, no pericardial effusion. Thank you, Dr. Sharma.
Yeah, no, Stam, based on you have seen so many of these surgical valves, and the patient that does not have a renal failure, or hyper.
So so the patient actually has CKD and also
But
has
CKD,
creatinine's been around 1.8,
Yeah,
1.9,
1.8. I'm saying, but not the CKD is still
and
okay.
also
But
cirrhosis.
yeah,
He's cirrhotic as
cirrhosis,
well.
yes.
Yeah.
Patient did have a cirrhosis, and portal vein thrombosis and many other things have happened, but definitely not the region unless I don't know whether we evaluated patient for parathyroid or adenoma or something high, but calcium values are normal. But to have such a valve degeneration within 4 years, which very unusual, right?
Yeah. I think it's a combination of
Patient
degeneration
persistent
and most
mismatch, yeah.
likely ppm, some ppm too,
Okay, so ppm, I was told that just a very small component here, or no?
Yeah. Combination of both.
Yeah, and not a regurgitation.
No
It's-
regurgitation,
yeah.
no. Minimal PVL,
Okay.
no valvular AI.
Okay, very good, my friend. Okay, let's go back to our main presentation. So we continue now. This was the echo, and then CT. All right, who want to read about
Yeah,
Gilbert?
I can start. And basically, we know from the valve-in-valve app, 23 Inspiris has an internal diameter around 21, and this is what you see here. L-flow track's a little bit bigger. Next slide. So you can see big sinotubular junction, big sinuses. What we've done, if you look at the bottom pictures, is we drew a 23 millimeter transcatheter valve. And you can see now, I think with the TAV, we want to kind of make the language similar. So the top of the surgical valve, that's the neoscleral plane. And you can see the red line is the left coronary wrist plane of CRP. And you can see that the neoscleral plane is a little bit higher than the coronary wrist plane at the left. So you to measure the distance, and you can see that it's around 3.7, so it's pretty safe. On the right coronary, you can see the right coronary is actually the coronary wrist plane is above the neoscleral plane. So there's no coronary obstruction issue for the right. So we don't have to worry about the right. We just have to worry about the left. In this case, it should be pretty safe, even if we stretch the valve. So here we want to comment on this further.
No, I think I was a little concerned initially with the height of 10, but your sinuses are pretty generous. So your VTC is 3.7. Now, whenever you're trying to fracture or stretch the valves, remember the VTC changes from what you're observing right now. And we've seen when you try to oversize them or stretch them, the VTC actually narrows down. So yeah, it's green zone right now, but that can change if you have a fracturable valve. Luckily, this is not a fracturable valve, so I think we should be able to get around 23 plus 2 here without any risk.
But what about you can modify the valve? What does that mean? You distend it?
So the way this valve is designed, it gives you that extra give to expand it. So some valves are fracturable, where you actually create a break in the frame of the valve. Right? Some valves like this can actually expand because they have an inherent give.
Okay.
And some valves won't do anything at all. Those you can just modify. That means you can stretch as much as you want, but more often than not, they return back to their original dimension.
Okay, very good. So this is, I think, the terminology we are going to use later. And anything new here?
No, this is just the different views of the surgical valve that we can pre-plan for implantation. You can see the arch anatomy, pretty straightforward. This is exactly what Sahil was mentioning. So if you see on the top left image, that's the valve looks like off the box. And in the middle, it actually tells you the size on floral, and that's where the hinge is. So the hinge actually can expand. That's what Sahil was mentioning. So you don't need to fracture this valve because, there's a hinge there. So obviously, if you put a ginormous balloon, it will break. But, that's not the purpose. The purpose is just expand enough so that you can actually put a larger valve or at least a better expanded valve, and that's what you see on the bottom left. In terms of how a 23 S3, for example, here in the same size valve would stretch. And that's why you see what is called expandable, not fracturable. It's called expandable for that reason. It's not remodeling, it's expandable. And Sahil said we're going to plan to use a 24 millimeter non-compliant balloon to stretch it before we implant the second valve.
Okay, beautiful. All right. And then, so Eki, you want to make any point on the balloon stretching of the valve?
No.
Okay, CT for access looks good, and the patient actually had a covered stent on the left common femoral artery. So coming back to the point presentation about this patient, which is a 69-year-old, has a bioprosthetic aortic valve degeneration, severe stenosis, maybe some PPM, and a heart team discussion with the surgical mortality of 11.1. Deemed appropriate for valve-in-valve TAVR. So plan to undergo valve-in-valve TAVR with a pre-balloon valve remodeling. So that's why the word it was used, not the fracture, remodeling. So there will be some expanded with the Inspiris aortic valve followed by implantation of a 23 millimeter SAPIEN with extra 2 cc's, right?
I think we should take a moment here to discuss the valve choice. Why are we using a short valve here versus could have been a self-expanding supraannular or intraannular valve? I think Sahil and Dr. Kini should try to have that discussion, but I think because that's relevant to the audience. We intentionally put a short valve here for a reason, I think.
Yeah, no, I think that's so two important points here. What valve choice to use for TAV and SAV, right? If PPM is really an issue, then you would want to have a valve that gives you better hemodynamics. So an ideal teaching on an ideal scenario would be a supraannular platform inside this to help you with the patient prosthesis mismatch and improving hemodynamics. But here you can see that the surgical valve has benefits in terms of its stretchability, if you will. So you can do a short frame intraannular valve as well, and that preserves your coronary reaccess. So there are multitude of benefits in using a smaller frame valve here, just because you have an Inspiris valve that can stretch. Now, if you have a valve that's not modifiable, is small, then you have to think about putting a supraannular valve for better hemodynamics.
Yeah, I think the other point is the patient's age, right? Yeah. The patient was 64, 63 when he had the first surgery.
64, yeah.
Now it's like 68 or 69, right? So, I think from a lifetime management standpoint, a short valve here will be beneficial, not just in terms of coronary access, but also maybe even the potential a third valve.
Yeah.
Rather than going back for a reop surgery, which you saw the STS score is 11%, so I think that's another strategy. We think, obviously, if you put a too small surgical valve now, a transcatheter valve, that is not going to benefit the patient. But I think luckily, I think they put in a valve that is expandable. And I think, with the Resilia technology on the SAPIEN-3 so far, all the data, I'm sure Dr. Sharma will show some of that have been better in terms of hemodynamics than the previous generation SAPIEN-3. So even SAPIEN-3 Ultra without the Resilia. So I think that this will give the patient a long possibility before their next intervention.
Yeah. So therefore, Pedro, the biggest reason here is you use a Evolute or you use a SAPIEN. I think part of that is the lifetime management of this patient who does not have CAD. As long as other things are considered, he could live another 15, 20 years. So you need to think about the third. And that we did a case live related to India where it was a 10-year cycle. Surgical valve, 10 years later TAVR valve, and now 10 years later. So already 20 years have passed by, and now patient is ready for the valve-in-valve. So that's what we did. Surgical valve, the valve-in-valve TAVR, and now we did a redo, or we call it the redo times 2. The TAVR did, and came out very good. So therefore, if you put the valve, the tall valve, probably it will decrease the chance of subsequent.
So the other thing about is need to understand is the valve design. So the Evolute valve here will be the 26 Evolute, and the waist is 22. Okay, so now remember, the 22 is just the frame.
Yeah.
There's tissue inside. So when that valve degenerate, even if you put another 23, let's say SAPIEN, a short and tall combination, you will never get to 23.
Yeah.
You may get to 21 and change. And so again, that will reduce your effective opening area. Whereas if you do a 23 S3 now, it should be well expanded because we're stretching the Inspiris valve. You can definitely put a 26 evolute or 25 Navitor in the future. Both have the better hemodynamic benefit. And so you then now sequence the next patient, the next valve for this patient.
Beautiful. Anu, tell us what is happening and you're changing some catheter.
Now we're trying to cross.
And what was the catheter before?
So
We
had an
tried AR1.
Say the best
But I
structural
think-
sonographer.
So
If you go back to the aogram, you see, yeah, this is a dilated.
So whenever you have a small
don't-
valve and
yeah.
huge sinuses, the wire tends to flop into the sinuses. So we like the guide. It makes it more centered, if you will.
You like the guide.
I like the guide, yeah.
Dr. Moreno, any questions from the audience that we can help?
No questions at the moment, but very interesting comments regarding a third TAVR, or, after the surgical 2 TAVRs. Considering the increasing use of TAVR
V19.
around the world, what will be the next step to have a 3 TAVRs? In other words, avoiding the first surgical approach. Is that considered going on, or is just too premature?
I think it is premature. Number one,
that's
and
it.
number two, you don't want to have a
Yeah,
Russian
always
doll
is.
effect, right?
Not the guide, it's
So,
AR2.
so I think that it really ultimately depends on the patient's anatomy and the site. And actually now at the heart team clinic, we talked about this. A lot of younger patients ask, how long does this valve last?
Yep.
What are my options afterwards? So it's actually, once we have the CAT scan, and we usually have the results within 24 hours, we can let them know actually the next day. We actually tell the patient.
Wow.
So we looked into our database. We have 12 cases of 3 TAVRs for whatever reason. Not necessarily that they lived 30 years, but 20. Some of them degenerated early. So we do have, but rare. The long-term survival, long-term outcome of those
Yeah,
will
think
be
about
very
the
questionable.
guides,
So
lot of
goal
guide.
should be that once you had talking about the 3, the 1 should be the surgical, and then 2 should be the
Absolutely.
the percutaneous, whichever. Because that's where you'll get a good hemodynamics, because you have a 3 TAVR valve. You know that your residual gradient probably always will be 30, 25, 30, because you'll not be able to get it further. So Anu, tell us now what you did.
Yeah, good
Okay.
maneuver.
Yeah.
We change it with the, you have the fluoros?
To AR2 now.
No, I would have gone with AR2, just a regular diagnostic. So I like the guide. This is a guide.
This is the guide you did.
Yeah,
AR2 guide.
AR2. And the reason for AR2, normally we say AR1 is good. I showed you earlier. Look at here. It's a dilated root. So once you have a dilated root and a valve that is smaller, then you may need a larger catheter to cross.
Maggot, please.
I mean, I
So now
thought
we
you
are
would have
going to
gone with the
change.
AR1 also in this case. To be
We tried the AR1.
You've seen it.
But yes, AR2 is the workhorse catheter, guide or diagnostic. That's your choice
Detail, please.
as a first catheter to cross the valve.
No,
And it does good
AR2
job.
for native.
Yeah,
for,
native, yeah.
For bioprosthetic, it's AR1.
AR1. That's what we usually do.
surgical bioprosthetic.
But in
If
this
it is-
case, did not work.
If it is a TAVR valve, you can just use pigtails. Means if you are trying to cross TAVR, SAPIEN or Evolute, you can use a pigtail in many cases.
So one benefit of using the guides, especially if you're trying to do redo TAVR with an Evolute platform, is that the guide will never go through the strut of the tall frame. What we have seen people struggle is they'll cross the tall frame valve
You do hemo.
and the wire is, it's already done. The wire will go through the frame and it makes it challenging. So that's why we like the guides for those cases. Otherwise, for most of them, diagnostic catheters is enough.
So now you put a pigtail and now you're putting a
But
Safari wire,
cross-
yeah.
safari wire because to modify the valve, to kind of stretch it. All right, let's get the stretching team.
Tidal volume.
Now,
I don't
along
want
those lines, it is interesting that a surgical valve has this capacity to stretch. What was the rationale in the design? Just thinking about TAVR, I think that will be very advanced, huh? What do you
Yep.
think, Dr.
That is
Tang?
true.
That
No,
was
but I
the
can
whole-
tell you what is happening is there is a trial going on called Complete TAVR. Complete TAVR is the patient after the TAVR, if he has coronary artery disease, randomizing into PCI or medical therapy, maximum medical therapy. They actually are asking that after 5 years, you do a hemodynamics. But not means mandated, but do a
150,
hemodynamics.
go in
If
a
there is some stenosis, you start getting gradient of 30 or 40. Maybe do a balloon,
150.
gentle balloon dilatation. So this is the concept
Who is
of the
facing?
TAVR balloon dilatation is there, and it's just taking shape. Everybody is very much worried about at this time. Do a BAV of the TAVR valve. Means
Okay, back up.
independent, not as an adjunct to the another tower, but just independent. And I think it makes sense. Why you have to wait when gradient become 80? Maybe you had 5 years, the gradient is 20, 30. Maybe you do it and bring down to 10, gives you extra few years. So this is concept in evolution. They're doing a BAV in a moderately stenosed tower valve. And when it is severe, of course, then you have to go with a valve-in-valve tower, or patient may need surgery. But I think this concept of the gradual measurement of hemodynamics, and once it's narrow, you start doing the BAV in those cases, is a reasonable approach, in my opinion, for the years to come.
Excellent.
Okay, skirt is ventricular, orientation confirmed.
And same thing is that I can tell you to be just as a very proactive and following the data, that when we say surgical valve, we're telling our patients that the valve will last between 10 to 12 years. In the past, I was very proponent that the tower also lasts the same time, but answer is we learned that it does not last same month. We are telling now the tower will last between 8 to 10 years, and surgical valve will last 10 to 12 years. And that is supported by multiple data now on the long term, which is the 10-year follow-ups. And I'll show you some of them.
Yeah, on the pathophysiology of these valves that are restenosed, let's call it like that,
Yeah.
the coarse calcification is not there. It's just fusion of the commissure. So it may well be that balloon goes through the commissure that is fused, and then we'll do a good result.
Stretch, yeah. I mean, same thing as a mitral, we want to split the
Exactly.
commissure, but we just dilate.
Can we dim the lights a little?
All right, let's put the lights down, please. Okay, tell us, your pigtail is up there, or
Yeah,
you don't
yeah.
need to?
We don't really
We
need
don't
a
need.
pigtail here.
Okay. So what are your landmarks?
So,
Trying to do a little outflow to outflow here.
Okay.
And because the coronaries are a little bit on the lower side, so you don't want to be too high. I think this looks reasonable. Let's go a little cranial. So trying to get the 2-1 view, Dr. Moreno, you're lining up, overlapping the two posts. You see that?
Yep.
Now, can it adversely react to your mitral ring?
No,
It's far away.
It should be
yeah.
clear.
Yeah,
You can
okay.
see it on the bottom of
Pace
the
180, we're going to test pace. Back up.
lungs down.
Looks good,
Okay.
actually.
Yeah.
Okay,
lungs down.
lungs down. Pace 180. Keep pacing. Keep pacing. Back up, lungs up. Lungs up. Thank
Good.
you. Okay, let's take an aortogram. Pace 80, please. Ready?
Yeah, go.
Wow.
Very nice.
Wow.
Let's do one more
But the
inflation.
key is the gradient. But you do a post
Let's do one
step
more
and then do the
inflation,
gradient.
Pull back.
Because in this case,
the wire
regurgitation
back.
was not the issue.
Pull back the wire a little bit. Okay.
Okay, lungs down.
Do you want to add some extra?
180.
No. Do you want to extra cc's or no?
No.
It was 2 extra cc's already? Okay. Oh, good. Okay.
Expanded.
Yeah.
Yeah.
Way up to 8.
Keep pacing, keep pacing, keep pacing. Back up, lungs back up.
You have the pigtail ready?
Okay. Come down, come down.
All the way out. So you can see, Dr. Sharma, it's away from the mitral, right? You have enough space there, enough clearance. Good, let's get the pigtail. Stam, you can do some echo if you want.
Get the radiation now.
Stamatios, you can do some echo, yeah.
Okay, Prof. Let's put some color there.
Now, if there is a high gradient, and what should be the cutoff, and what would you do? Let's say gradient is 20. Radial gradient is 20. What is the next step?
I mean, we'll have to stretch it more, but that's about it.
Okay.
I can't do much here.
Well, right now, you did probably kind of 24, right? 23 plus 2, which is each one we say is about 0.75. So they did like 24.2.
24, yeah.
24.2.
Oi.
How much?
Mm-hmm.
Yeah, mean gradient
Did
12.
you zero both?
Yeah, just 1 second.
Okay, show the live echo before we go into the hemodynamics.
Yes, this deep gastric.
Mm-hmm.
No PVL, no valvular AR.
Good, no gradient.
This is the gradient we get. Take a measure, Prof.
Zero everything.
Peak 18.
How much?
About 10.
We-
Look at that. Okay.
Okay, good. Zero is good. Opening.
Let's see here, Prof.
22.
So you can show the gradients. There's no invasive gradient here. Almost zero invasive
Hey
gradient.
guys, show the. Oh, okay,
Yeah.
we cannot.
Looks great.
Okay.
Unbelievable.
Can you go fluoro?
Okay, put a.
Show the fluoro and this by the side. I need to trim it. You can't put
It is the color
this
of.
screen.
And no PVL.
Yeah.
We landed where we wanted. Inflow to inflow, outflow to outflow.
Let me see. Short axis here. No PVL, nothing.
Looks good, Stam.
Yeah, very good, man. Very
Okay.
good.
Therefore, hemodynamics point of view and valve deployment, nothing more to be done.
Correct. Looks beautiful. Even in his
take
post-ectopic
that, take
bead,
that.
there is no
Take that,
gradient.
take that.
Yeah, not post-ectopic also, yeah.
So we'll do an aortogram now. Just to,
Now the guidelines.
No, we're done.
We're done.
Yeah.
I want to check the left vein.
White
No, no,
open.
we good.
Final aortogram.
Coronary
saw it.
is
No, no,
white
I
open.
want to.
Yeah.
I want to check the biopsy.
Okay, great. Take that.
Okay, you want to engage? Okay, that's fine.
No, just the aortogram.
Yeah, aortogram. Okay, another aortogram. Yeah.
So very few surgeons like aortogram. Gilbert actually loves aortogram. He spent
Me
too much
too.
time with
Me
us.
too. Believe me, I love it too.
So
Correct.
Okay.
beautiful.
Thank you, sir. Thank you very much.
Okay.
So I want to do this to show the point that Sahil mentioned earlier about when you stretch
Stretches, yeah.
the valve,
Yeah.
that distance actually decrease and that surgical leaflet get closer to the left main. So you want to be able to see, make sure there's no subacute. So the patient may go home, but then within 30 days may have actually other issues. So but this is very reassuring. You see that? You can see actually the white line. So
And there's a good flow in the left main, so
Yeah.
that's very reassuring.
Yeah.
Hemodynamically, patient has done very well. And we can put the lights on a little bit now.
Yeah.
and Dr. Keating and Sahil intentionally positioned the SAPIEN a little bit more aortic. You see that here above the surgical valve frame to get the outflow bigger, to get the bigger EOA. So, if you put the valve a little bit too ventricular, closer to mitral, you're not going to expand because the surgical commissures are restricting you. Even though you expand it, there's still, that plastic surgical frame that is restricting you. So this gives you better, more outflow.
And looking at the mitral, Sam,
Yes.
what is your prediction? When we'll need to a TMVR in this case?
Oh, in 4 weeks. 4 weeks.
It will need to be fixed. Dr. Sharma, it will need to be fixed. It's,
Another live case.
I think this.
Nobody knows. Now, 1 year, 2 year, 3 year,
no,
4
4
years.
weeks.
I think,
4 weeks.
4 weeks?
Soon, yeah.
No, but why? You call it a mild
No.
process?
No, mitral
Stenosis.
gradient is almost 16.
But
Yeah.
how? But your echo was mild. We have the echo report. You wrote
Yeah,
down
no,
mild mitral bioprosthetic stenosis.
No,
that
no.
was read last time.
I mean, I didn't do the
Its
report,
gradient's
but
high.
the mitral valve area is 1.2. Severe.
No,
MS.
but that's a TE. Show. It's opening.
The gradient of 10, 11. Mean gradient.
Okay.
No, it's opening.
No, mitral disease. The patient came
Okay,
from mitral.
so therefore it looks like it will be a case for mitral. The timing wise, we know the T gradients and we less rely. We want to do it in the when patient is in stable conditions. At that time, we'll do a transthoracic gradient again. After 1 month, will be done. And I just saying that I'm reading it. It was read as a mild bioprosthetic mitral stenosis last time. And so if it get degenerated.
But this is a very good question for discussion. I don't know if the audience have brought up any question. How do you sequence double valve disease into prosthetic valve degeneration? So because the mitral always use a balloon expandable valve, that's the only one available, you have to do the aortic first. If you use the mitral first, then the aortic has to be a self-expanding valve, and you cannot pre-oppose that. We did a case yesterday like that, because if you use the balloon for the aortic position, it's going to crush the SAPIEN valve in the mitral position. So very, very important to sequence this appropriately if you have two prosthetic valve disease, especially both are severely, degenerated.
Okay, very good. And maybe for audience and maybe my understanding, so Stem, if you can show the mitral valve once again.
Yes.
With your all this funny Doppler, 4D mitral and all those funny things.
Yes. So we are here, we're on 3D. We try to do a 3D image of the mitral to show you.
Next month is the first week. Next month is the first week, not second week.
So if we can show
Like
the real life.
August.
Look very nice, Stem. Can you explain to the audience what we're looking at and,
Yeah, so basically this is, on the top is the aorta,
Show me
the
the
12
August.
o'clock, and these are the 3 leaflets, as you can see. One of the 3 leaflets doesn't move at all, the other 2 are thickened and also with decreased motion. So if we measure this with a multi-view at the tip of the leaflets, and we got 1.2 centimeters square, which is consistent with severe mitral stenosis. There is no minimal valvular MR and no PVL at all. So
this is consistent with a bovine pericardial valve degeneration, right? So porcine valve tend to fail with flare or regurgitation. Bovine pericardial valve, just like aortic position or mitral, fail by stenosis.
The mean gradient between 9 to 11. So
any comments on pulmonary hypertension, Stam?
No pulmonary hypertension by echo.
It was no pulmonary hypertension at the baseline, and even today, there's no pulmonary hypertension.
And the right heart cath as well showed the PA pressures weren't high and the
normal.
RV systolic pressure was very good, so well compensated at this point.
Okay.
Very good.
If everybody's okay from this case performance point of view, unless there is some question have been asked by any of us.
I've been trying to excite our audience, but they are very quiet today.
Okay,
so no
that's
questions.
All right. That's okay. So let's go to our presentation. Today we are going to talk about valve-in-valve TAVR, the publications on this field, and something about surgery. And usually we don't talk about surgical valve outcomes alone. And then the degeneration management and the leaflet modification and the short and long-term outcomes after redo SAVR or valve-in-valve TAVR. So as you can see here, the observational studies, so clearly say on the left side, the patients who have the mechanical does great. So chances of reintervention is like even of 10, 15 years is 25%, except they have issues in terms of bleeding. Now, the bioprosthetic, which is in the center, blue, as you can see, at 10 years, 50% degeneration, or 52% or so. So therefore, key is that these valves do last about 10 years quite well. Now, right side is the propensity matched TAVI procedure with the severe AS and the surgery. And you can see the surgical valve definitely lasts better than TAVR valve. 10-year follow-up on this observant study. So, but we know that all will degenerate. Now then, also we have been shown that basically the surgical valve after replacement they're dependent on various factors. One of them, surgical STS score, then age of operation. Valve placed in surgery, earlier the age, more degeneration, faster degeneration it occurs. And the lastly, that based on what valve size is, as you can see here, the ejection fraction all determine the subsequent valve outcomes, surgical valve outcomes. But Overall, looks very good in the survival point of view, and the reintervention occurs in a small percent of cases. Now, this is a trial which everybody was waiting for, called COMMENCE trial of the surgical Resilia Inspiris surgical valve. Because the data have shown very low degeneration at 1 year. I mean, up to 1 year, 5 years, and 7 years. This is the time, the last STS meeting about last month presented in May, the 10-year follow-up, that there is a 98% freedom from structural valve deterioration. Wow. That's really amazing, 98%. And of course, sustained hemodynamic performance, including stable gradients and effective orifice area. So this is the same Resilia tissue which we are using now in our current TAVR valve. Only thing is we are using only for 4 years. This had been, for the surgeons, they have been using for 10, 15, 20 years and so. And you can see, look at the chances of event, extremely, extremely low. Does happen, but very small percentage get into a trouble. And freedom from all those activities remain quite well. So unfortunately, in our case, the patient didn't read this article and degenerated in 4 years. So does happen with everywhere, no matter what it is. But this didn't last 10 years and so, but that we need to know. So therefore, practical issues, very important, that why the valve-in-valve TAVR is a little different than the native valve TAVR. So 6 important points. First is coronary obstruction, almost 5 to 7 times higher than the native valve TAVR. A big issue, and clearly the leaflet of the surgical valve are the one which abut to the coronaries and will create trouble. Second, patient prosthetic mismatch, PPM, because you have the valve inside surgical, it basically becomes a limited expansion and have a higher residual gradient. Challenging future coronary access. Like this case, now you can see, we saw that because of the expansion, now the left main is coming just below the frame of the current valve. So it may be tricky at that time or may not be tricky, but this is something issue that not at time 0, no coronary obstruction occurred, but now engaging the coronaries in the future will be tremendously trouble. Then the PVL, in case did not happen, but something happened because you don't have the perfect fit with the 2 valves, the frame under expansion, and lastly, anything happened with the procedural complications. So all these, whether stroke, conduction disturbance, a lot of people used to think there will be a higher stroke rate. So some of the studies require the sentinel device 100% of these cases, but now it totally has come out, and the latest data, even in valve-in-valve TAVR, sentinel device is being used in teens. Overall, without the valve-in-valve TAVR, native TAVR is about 5 to 6%, about 18% in our STS registry. The sentinel device use embolic protection in about higher teens, which apparently does not happen, help or not is issue. So just to say, the biggest issue is the coronary obstruction. And therefore, many of these cases which you can do a TAVR, but they don't get the TAVR because of worry about the coronary obstruction. So even at the age of 80, you might end up in sending these patients for surgery, but this is where the whole things change. So clearly, bioprosthetic valve degeneration occurred because of structural, prosthetic mismatch, regurgitation, and then question comes is what to do. So these are followed just like anybody else. This is the surgical side. When the patients will periodically follow up, then the symptoms start. And patient has the high gradient, and now you have multidisciplinary heart team discussion, same. Good anatomy, VTC more than 4, valve amenable to fracture, intermediate or high surgical risk, the valve-in-valve TAVR with a bioprosthetic valve fracture, in those cases recommended. If there's unfavorable anatomy, a small root, if face sinuses, low coronaries, valve not amenable to fracture, urgent emergent surgery required, underlying conduction abnormality, redo surgical aortic valve replacement with consideration for future TAVR. You're going to put a valve that in this particular case, you have taken the old valve, now you put a new. Because old one was maybe 10, 15 years ago, we are not thinking about the TAVR. Now you have to put a valve, whether it's a stentless or various types which give you better lumen, and more importantly, future use of the TAVR. So Gilbert, I wanted to understand this, why they still have valve-in-valve TAVR only for intermediate and surgical risk. Is there any low-risk trial which showed better that redo SAVR better than valve-in-valve? Why we are not doing valve-in-valve TAVR in every patient if its anatomy is suitable?
So partner has had a registry, single arm, but they have not published it. the results. So they did as part of 3, a single nested registry for low and intermediate risk, because right now technically valve-in-valve TAVR for TAV in sub is only approved for high surgical risk patients, but they have not expanded the risk yet because the numbers are small.
Yeah.
Right. I mean, and also TAV in TAV is going to be taking over. So that's why I don't think the companies are going after that expanded indication. So,
but point is, if we do a low surgical risk patient with a TAV in TAV,
the concern is going to be durability. That's all. Yeah.
Very good point. So key is that it's basically that if you need to do a second and the third procedure, that really will create a trouble in the future. Now, when do you do what? So if you have valve degeneration, if you're decreased, either you do a valve-in-valve or redo surgery. Short-term MACE are lower with the valve-in-valve, which we know that. Long-term seems to be lower mortality and lower need for reoperation in the surgical valve, which you also understand. This is Gilbert's nice central the central illustration on this Jack Asia, talking about the valve-in-valve procedures, that various challenges with a small aortic root, leaflet modification, and then of course the individual valve design, and then lastly the socio-economic factors. So I've asked just Gilbert to comment on it. It's very beautiful in one slide. Everything puts together what the problem is with the valve-in-valve.
Well, Asian population more specific, right? Same as Indian patients that have small anatomy. Problem with small anatomy, as we know, that once you have the first valve in, it's very hard to do a TAVR in because you've got coronary obstruction, as you said. So thankfully now we have leaflet modification technologies, but of course they are expensive. So from a socioeconomic standpoint, most of them went for reop surgery for a very simple reason, is that it's much lower cost to do another surgery, and usually if they're, like you said, low risk, they can get it done relatively well. TAVR is still quite expensive in that part of the world, and that's what this Jack Asia, the paper is about, in terms of, yes, in Japan, they're also growing, just like the US, but it's slower because patients live longer, so they present much later.
And as you made it right as the part of the central figure, the leaflet modification is the essential part.
Yes.
When you are embarking on the valve-in-valve TAVR, you need to know about the leaflet modification. Very important. Otherwise, half of the cases you may not be able to do, or maybe not half, maybe 30% of cases. They're beautiful written. So then, with Sunny Goyal, with help of Dr. Keeney and Dr. Gilbert Tang, everyone wrote down a very nice Euro intervention, the leaflet modification technique to mitigate coronary obstruction risk during transcatheter aortic valve implantation, and he has done extremely. Anu, you helped in making this central figure. Tell us a little more on this. They put it all the techniques, basilica, cathedral, unicorn, shortcut, splitter, and the unicorn actually comes, there are few names, cleave, telltale, all those are that you are splitting the leaflet. One by the non-device means usually your ingrown devices, or you have now the commercially available shortcut. I don't know whether splitter is available commercially.
No.
But shortcut is clearly available, and so you just cut the leaflet. So Anu, you want to comment on this beautiful slide? I mean, this is fantastic.
No, if you can see, it is everything is self-explanatory, and we have mentioned it in the side just at the beginning. So what is basilica exactly? And you see that where you place the catheter, how you go through the leaflet, everything. Just with 1 or 2 lines, you are able to understand what the technique is. You don't need to read the whole procedural thing. So I think essentially, if you can understand basilica and unicorn, probably the 2 important procedures if people want to learn. The simple ones, and of course the expensive one is the shortcut, which is, you can say, which we have shown during our symposium. How to exactly use it. You'll need echo and fluoroscopy to exactly place the blades and have modification on you cut the leaflet.
So therefore, the unicorn is just to tell everybody, simple. What we are doing is they're making a hole in the leaflet.
Yeah.
And then split it, whether completely or partially. Compared to unicorn, make a through and through cut. But the shortcut will make a through and through cut. So unicorn, cleave, telltale, all just going through the leaflet. And I can tell you, some people actually, their case report, if you have aortic regurgitation, When there's no calcium, now of course we have the the Jena valve will be available, and we'll be doing cases in next few weeks, and hopefully some aortic case in next few months will show as a live case the Jena valve. But key is that in pure aortic regurgitation, if you go through the leaflet, your valve will be stable, will not fly. And therefore, people have used this kind of unicorn technique, not exactly, but basically just make a hole in the leaflet so that your TAVR valve without calcium stays there. So key is unicorn will be simpler than basilica. Now, we are done at Sinai, basilica. How many cases we are done?
We've done few, around 10. Unicorn, I think it's simpler, yes, but I could be more unpredictable.
Okay.
Especially if you're trying to land a self-expanding tall frame valve inside a sort of torn leaflet. So delivery may be very challenging. There's a paper published now which tells you exactly what size balloon to use, 12 and 14 for what size valve you're using. But that is one of the challenges with the unicorn, where delivery of your second valve, because the leaflet, unless the leaflet is fully sheared, that's a different thing. But if it's not fully sheared, it may impede the delivery of your catheter. So yes, it's not one size fits all. You have to see which is best for which patient. All surgical valves have inherent commissural alignment, so that's not an issue. So basilica is very good. Balloon assisted basilica has been shown to give you a bigger coronary clearance. So you can put a balloon and then do the basilica, that's bar basilica. And then third is your unicorn, where you're completely sharing the leaflets. But again, you may have an unpredictable sharing of the leaflets and your device may not deliver. So just a few things to watch out for. And I think everyone should start with basilica and then go towards more of, bar basilica and unicorn.
But I can tell you that based on the literature, that hemodynamic instability occurs more with basilica than unicorn.
Well, so hemodynamic instability occurs if your primary valve pathology is stenosis.
Mm-hmm.
If your primary valve pathology is regurgitation, then you should not really have much of an instability, because those patients are already used to. It's the severely calcified stenotic valves where you can have any leaflet modification can push you towards instability. So that's why when we do it, we keep a wire, a safari wire already across, just to go. When you do the basilica, you have a wire that's across. So if you have instability, you pace at a higher rate and you deploy a valve.
And also, most of the data of the valve-in-valve after the leaflet is splitting are with the balloon expandable.
That is correct. That is correct.
The question is, will the valve and the splitting will work in the self-expanding valve also? I know there's some data which I'll show the slide.
Yeah.
But why should it work? Because there is already still the tall frame.
Yeah. So again, it comes back to TAV cases where your initial valve is an evolute or a tall frame supraannular valve.
Yeah.
They have tall leaflets. So you have to see that your commissure plane, the wrist plane is higher, the leaflets are taller. It's very hard to predict where you're splicing or where you're cutting. So you would like to be at the base so you get a full splay, but if you're mid or tip, then it becomes very challenging. So the unpredictability goes up as your frame size is bigger and your leaflets are taller.
Beautiful, beautiful. Okay. And as you mentioned, the basilica, the shortcut, and basilica registry shown there, complications and all, just very small. The hemodynamic compromise was kind of in this trial. See that basilica was 7% versus 1.7, very small. But and then the BA basilica shortcut, and unicorn, as we have clearly discussed. And if you think about all the catheter, things needed on the top are this technique. And if you think about what is the cost of for the basilica and for unicorn, probably $2,000. While you have the shortcut, which is very deliverable device, very predictable, it's $15,000 and it's not reimbursable. Everybody says it's reimbursable. Answer that is no. It can only reimburse if your DRG goes beyond the 225. And there's very rarely DRG of acute, your TAVR will be 225. So this is what the notion going around, that the basilica, the shortcut will reimburse the 10,000 by starting January, which is absolutely wrong. It is attached to that if your DRG, which is 256 to 257, it goes beyond. If it goes beyond 225, then only you get the 10,000 rebate. So we actually have done it, and we have only one case. How many we have? 8 or 10? How many we done short case?
No, we've done more than that.
Yeah, and we only reimburse one. n equal to 1. So I just want to say that we want to use the great technology, but if you get a little expert in the unicorn or basilica, it probably will be more cost effective compared to, except that shortcut is very simpler. It takes just few minutes to do it. And so then validation of the unicorn technique, they have done it, all types of valve except the Navitor. They say that you are able to make a hole very nicely in all of them, SAPIEN, Accurate, and Evolute, but the Navitor didn't behave well on the bench testing for these valves. And then to first experience just to how to do a technique we have spoken about. This was the first case published about 5 years ago from China. More importantly, then now you have a unicorn before the bioprosthetic multi-center study. The same as mentioned by Sahil earlier, that leaflet deployment, and question is that what you want to do. Native in tau in tau, number percentage you there, and that based on the balloon size.
Okay, come out.
Intra-leaflet deployment or full tearing, which is using the bigger balloon. They actually have the whole algorithms and AI technology which will tell you which balloon to use. But overall, unicorn does very well with a very low complication. You see the death rate, 0. Hypotension, others are there, and very safe procedure once you learn it. Then the Cleveland Clinic guys came up with a different one called Cleave, also the same way. The goal is they have different than unicorn, they call it a Cleave, and go through the either aortic valve leaflet or the mitral valve leaflet, and same. Open it, some little minor device changes, they call it a Cleave procedure. But if clearly the size of the valve, the 12 millimeter balloon, valve deployment, and you can see mitral and aortic can be used. And I would say the aortic valve and valve types are unicorn, and now they call it mitral valve and valve as a Batman, going through the leaflet and putting the TVR, TMVR valve. There's another one, Telltale. These are abbreviations or type of. Now, you want to get a real pathological tissue? Look at the Mount Sinai. We did this case. This is the leaflet retrieved by shortcut. And we tried to ask them, but they didn't say anybody has such a nice leaflet.
So this was the case we did at New York Valves. This was a live case. And what happened was the initial split was in the mid leaflet, and the second split, which was a better split, was at the base. And when we were pulling the device back to split it, I think it took the entire leaflet with it. So if you have very calcified valve and you have you're trying multiple times and you have 2 splits, this can potentially happen. And luckily no stroke, but that's a feared complication in these cases, that you can have a CVA, and it could be pretty, drastic.
And this one did not have any hemodynamic compromise. Also, and rapidly we replaced the valve, and patient did subsequently fine. So then midterm outcome of the balloon expandable aortic valve in United States, and you can see basically the death, stroke, balloon expandable versus they actually have the native versus the aortic valve in valve. Clearly the event rate will be higher, and various characteristics which will create have been shown on the right side. And of course, if you develop the patient prosthetic mismatch, outcomes are much worse, and based on the STS, risk will be, outcome will depend on it. Then there is the Ocean TAVI, which is the same transcatheter aortic valve replacement in the failed small surgical bioprosthesis. And this also showed that yes, you have a good acute hemodynamic results up to 3-year follow-up, and it's also dependent on the surgical valve size. Or second is, if you have a patient prosthetic mismatch and you have a small valve, the event rate is tremendously higher. You can see the 40% at 3 years. I mean, that's basically the bad news. So kind of we learn, avoid in those small valves, which is going to create a trouble in these patients. And lastly, the Lighten trial, which we presented a long time ago. There's one trial of the small annuli randomized to a balloon expandable or self-expanding, and showed at the short term similar outcome with a minor differences and so. So with that note, also we learned that the leaflet modification caused less halt at follow-up. This is a study which have the valve and valve tower, leaflet modification versus no leaflet modification. As you can see here, no leaflet modification. Those cases with follow-up MDCT, halt occurs in 40%. If you did a leaflet modification, occurs in 19.7%. And of course, they're associated with subsequent outcome. So clearly, the leaflet modification is fine. And now it's better actually, rather than just give you hemodynamic appearance. So therefore, take-home message, despite the excellent long-term survival and low incidence of re-intervention after SAVR, patients with SAVR degeneration are gradually increasing. These patients offer significant challenges in the re-intervention, and most important is basically to coronary obstruction by the leaflet, and therefore the splitting devices are available, whether you make an ingrown, homegrown, or use a dedicated with a $15,000 price tag. There are numerous studies which have reported excellent safety of midterm, and of course, if you do the splitting, you have a less halt, as has been shown. And lastly, heart team discussion should take place in all severe AS patients, not only elderly, not only on the coronary side or the cardiology side, surgeons also, because they have to think about the lifetime management, which surgical valve they are using. You have to think in 10 years, 12 years, 15 years. If that valve degenerate, is that valve ready for valve-in-valve TAVR? So that is what has to be thinking. So Gilbert, you want to comment on the last statement on that?
Yeah.
What is the thought process at present?
I think the the Inspiris valve is the market leader because it's expandable, like you see today, and I think it's also gut resilient tissue. So I think the heart team discussion has to be talking about what type of surgical, what size, and also we talked about before whether root enlargement is it's necessary to avoid PPM, and also to be able to make enough room, like you said, for the TAVR.
Yeah, perfect. Okay, let's go to our 3 questions. So we are by the dot. It started at 10, going to finish at 10. That's, I'm sure, AK will love that. Following are the potential causes
Doing
of
one is not going to give you a mark.
degeneration. Listen, at least one in the books. The structural surgical valve degeneration and long-term, except aortic regurgitation, valve migration, patient prosthetic mismatch, endocarditis. Clearly, the surgical valve does not migrate. Second, the valve-in-valve TAVR is associated with following potential complications, except higher rates of permanent pacemaker insertion, higher post-procedure aortic gradient, higher coronary obstruction, challenging future coronary access. Remember, pacemaker use is less in this valve-in-valve TAVR. Lastly, following are the correct outcome of valve-in-valve TAVR versus reduced SAVR, except reduced SAVR has better long-term survival. Yes, valve-in-valve TAVR has a shorter length of stay and ICU and in-hospital compared to redo TAVR. Similar rate of reintervention after valve-in-valve TAVR versus redo and redo SAVR. And most studies have shown higher 30-day MACE after redo SAVR versus valve-in-valve TAVR. Clearly, the intervention is much higher in the valve-in-valve TAVR versus redo SAVR. With that note, we present and we actually thank our BroadMed AV providing this excellent audio-visual presentation for this CCC live case. And thank you very much. If any questions, we can answer them. Otherwise, we are all right on the dot.
Yeah, no questions. Thank you so much for the heart team members of the Cath Lab for being incredible case. Thank you for joining us today for this fantastic transmission. And remember, this afternoon, you can review this case at ccclivecases.org. Remember, we do our structural heart cases usually on the second Tuesday of the month. However, for the next month in August, we're going to be on August the 4th. So the first Tuesday of the month. Thank you so much and see you there.